Thank you. Morning, everyone. So I'm the Dermatology Registrar at Medway Trust in Kent, and I'm going to talk to you today about our Teledermatology service. So firstly, some background. Our trust is in West Kent, in the southeast of England. Covering this area here. We serve a population of 1 million people, and currently we have 5 to 6 dermatology consultants. So dermatology is said to be a speciality in crisis in the UK, as many of you know. The Royal College of Physicians recommends 1.6 dermatologists per 100,000 people. Given our current population, this creates a shortfall of around 300 dermatologists. Along with increasing numbers of GP referrals and rapidly increasing skin cancer rates, there's a clear unmet need for dermatology services in the UK. And if we just look at the specialist dermatologist numbers per 100,000 in England, you can see here, according to region, that nowhere is meeting the RCP target, even in London. And where we are, despite being the so-called Garden of England in the southeast, we have the lowest consultant ratio per 100,000. So this chart here just shows our referral numbers to our area, just to give you an idea. So the seasonal variation, as most people see, they're ranging from 1,100 to 1,600 per month. And this chart here sort of quite strikingly demonstrates the rapidly increasing skin cancer referral numbers. As you can see this is just to our area in West Kent, 2009, they're around 200. Again, you've got seasonal variation. In August of this year, they hit over 700. So a threefold increase in just 7 years. So given that there's a clear need to manage this rapidly increasing demand, we set up a teledermatology service in our area. We have two systems, in-house system using an eSeptionist platform, which we set up in 2004, and we use this mainly for skin lesions. And then we have a community service using the SIOS platform, which we set up in 2011. I was paying attention to that. Mainly used for dermatoses. So first of all, I'm just going to go through our in-house setup. So this consists of virtual clinics, which is led by trained dermatology nurses. They see the patients, take a detailed history using a proforma, examine the patients, and they take clinical images with a Nikon SLR camera, and they take dermoscopic images as well. As mentioned, this is mainly used for lesions. Currently, we have 4 reporting consultants, and we have dedicated admin staff as well. So this is just a shot of the eSeptionist platform that we use. You can see patient information here, a selection of clinical and dermoscopic images, as well as the referral information. The nurse then enters the detailed history using the proforma. The consultant can then look at the images, again on a full screen, scrolling through clinical and dermoscopic images, and can then enter diagnosis with free text descriptions, treatment plan, and recommendations that are then emailed to posted to the GP and the patient. So this chart here just shows the numbers that we've seen since 2004 until April 2016. You can see total numbers over 30,000. So I looked at the coding of all these cases. In the last 12 years, you can see 62% have been coded, 38% were not coded. This is mainly due to the lack of availability of coding in the early years and the fact this was not a mandatory field. So if we just look at those cases that were coded, 77% were lesions, 7% were dermatoses, and in 17%, a case of diagnosis not made or pending was given. So I realise this is quite small, but this just shows the frequency of coded lesions that we've seen, ranging from benign nevus to myxoid cyst. And I've just put the top 10 here, perhaps as expected: benign nevus, seborrheic keratosis, and BCC, the top 3. Just looking at the coded dermatoses that we've seen, obviously these numbers are much smaller, ranging from eczema to alopecia. And then I've just put the top 10 here, again as expected: eczema, acne, rosacea, and psoriasis. So just looking at the outcomes, similar to what we've heard already, about 50% in the last 12 years have been sent back to the GP with advice. About a third have been booked straight for surgery, and then 17% are booked for a face-to-face appointment, and the reporting consultant is able to sort of grade this, whether they need to be seen in 2 weeks and 4 weeks and so on. Just looking at patient feedback, which has been very good. This is a survey that we did a few years ago. It showed that 82% of respondents felt that the encounter was very good or good. So I thought it would be interesting to look at the subset of patients in which a code of diagnosis pending or diagnosis not made was given. This, as I've mentioned before, makes up 17%, so quite a large amount of the total. So I randomly selected 200 cases from January 2015 to January 2016. You can see the outcomes here. So around half of them were booked for surgery, 40% came back for an appointment, 5% didn't attend, and around 7% there was no abnormalities seen, and a few of these were referred directly to another provider or for investigations. So I then looked at all those patients that attended for surgery, for either biopsy or excision. I looked at the free text entry by the reporting consultant as to what their impression of the diagnosis was. I then compared this to the histological diagnosis. So you can see 72 attended. I excluded 5 as no biopsy was indicated. So in 63% of cases there was concordance with the provisional diagnosis. In 37% there was discordance. 7 of these were ultimately malignant, and 18 were benign. I don't expect you to see this table clearly, but this is just all of the cases that we saw, and those that are highlighted in yellow are the concordant cases, which was the majority, 63%. And given that this subset suggests a degree of diagnostic uncertainty, I think this is pretty good. So these cases here, the 7 discordant malignant cases, you might not be able to see, but I'll just go through them. So this one was felt to be an AK or BCC, booked for a routine biopsy. The biopsy showed an SCC. It's difficult to say. That lesion might have changed. There might have been evolution prior to that biopsy. The rest were felt to be dysplastic nevi. Most of these were in situ or superficial spreading melanomas, apart from one BCC. And you can see that all of these were booked for either A or B, which is either 2 weeks or 4 weeks excision. So it's sort of difficult to make solid conclusions from this, but I think that there were 7 cases of missed sort of malignant lesions, but arguably the outcome might not have been that different if they were actually seen in clinic, given that most of them were all seen within 4 weeks. So I then just looked at those cases that were booked for face-to-face appointment, and I looked at the reporting consultant rationale for the decision. And you can just see here that there's a few operator-dependent reasons for this: incorrect site being photographed, the images being out of focus. So these are things we can kind of feed back to our nurses. The majority of cases were independent of the operator, and in most cases the consultant just felt that they were unable to make a diagnosis from the images. So I then looked at this set of patients to see if we could learn anything from that. And the main conclusions from this, so I looked at all the clinic notes of these patients, are that 35% of them were sort of red patches. So a few examples here. So differentials including AK bone and superficial BCC. 20% of them were dermatoses, which is higher than we normally see. And a few of them were in difficult sites. We mentioned that already, for example, like the eye and possibly the nail, which might not be as suitable for teledermatology. So just one other point is that there may be an element of consultant variability for selecting this diagnosis. And you can see that this does vary according to our 4 consultants. So the main conclusions I've listed here. In addition, 30% were possible melanoma. Given that these letters are sent to the GP and patient, that might be another explanation for this. And I've highlighted a few limitations, as I've mentioned already, operator factors and lack of suitability potentially for some sites. So now just moving on to our community service. So this is a GP-led service. We introduced this in 2011 following a 6-month pilot. GPs are given cameras and education. This is mainly used for dermatoses, and we use the SIOS platform for this. So this is just a screenshot of a patient record. You can see patient images there. Obviously, will be of variable quality, given from the GP with patient data. The GP then enters the brief clinical question with relevant history. The reporting consultant can then describe the findings, give the diagnosis. They're able to ask the GP questions, and the GP can then respond back with those and then give treatment recommendations. So these are the numbers that we've seen since introduction. Again, just until April of this year, we've seen over 3,000 cases. So just looking at the outcomes of the teleconsultation, so all GPs are asked after each teleconsultation, would you still refer this patient if teledermatology would not be available? So that's kind of this here. And then after receiving the result, would you still refer the patient to secondary care? So this is not compulsory. You can see that 2,000 GPs have answered sort of over the last 5 years. The majority of these would have referred. Of those that would have referred, 67% have not referred on, so we can see this as the reduced physical referral rate. It's important to note that there's a second arm here, which we kind of briefly touched on sort of this morning, and that actually 18% wouldn't have referred, so this is the kind of increased burden using this service, and that actually 14% of these went on to refer. So this is kind of increasing the burden and the demand for secondary care, although if you look at the total numbers, this is only 2.5% of what we've actually seen. It's only is less than 10 a year, so small numbers. And finally, just looking at the GP feedback, it's very, very good. Just every year, these are just the kind of average numbers that we're getting. Over 97% of GPs felt like they learned, and then over 98% every year felt that the answers were of use either to the GP or to their patient. So to conclude, we've set up and maintained successful in-house and community teledermatology services using the eSeptionist and SIOS platforms. This enables the streamlining and triaging of high volumes of increasing GP referrals. 50% of our cases in the last 12 years were sent back to the GP with advice. So about 2/3 of our community cases, a physical referral was prevented, although I've mentioned that there is a minority of extra referrals that are created. Feedback has shown consistently high GP and patient satisfaction for both systems, and I've just briefly touched on some limitations that it might not be as useful for some sites, red patches, dermatoses, possibly. Thanks very much.